Good morning, everybody. Good afternoon, good evening, depending on where you are logging in from. I am Rajiv Rimal. I am the chair of the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. The Centers for Communication Programs is housed within our department, and I am very happy to welcome all our participants to this webinar this morning. As of yesterday, roughly about 12 hours ago, we had almost 1,100 people who had registered for this webinar from 106 different countries and 450 organizations. So clearly, there is a great deal of interest in this underlying work. This work is a collaboration between the WHO, the World Health Organization, Massachusetts Institute of Technology, or MIT, Facebook, and the Johns Hopkins University Center for Communication Programs. This work started roughly about a month ago, and it was really based on the idea that emerging issues in COVID are rooted in human behavior. And that is why we want to understand and change behaviors to reduce the pandemic's effect. And it's also based on the idea that these changes are driven by a host of factors, including knowledge, attitudes, self-efficacy, social norms, public policy, and so on. We also know that these factors are not static. They themselves change over time, and they are probably culturally bound, meaning that predictors of human behavior are specific to cultural contexts and also the changing environment. And that is why the overall study that we have designed is very dynamic in nature. We're collecting data from multiple locations over time. And I'm very happy to share some of the preliminary findings from our team this morning. We also know that the data that we collect with regard to COVID has to be actionable, and that is sort of the reasoning behind our dashboards that you will hear a lot about this morning, that allows health communication professionals from throughout the world to plug in the numbers that are relevant to their setting, to their culture, and understand what kinds of approaches, strategies, communication channels, and other things like that are likely to be most effective. I do not want to take any more time, but I do want to invite Susan Cran, who is the director of the Center for Communication Programs. Let me just briefly tell you about Susan. She is the director of CCP and she has worked in 40 countries. The Center for Communication Programs itself has a staff of over 700, is active, like I said, in 40 countries. Susan has a 35 to 40-year career at Hopkins with extensive experience in safe motherhood, malaria, TB, HIV, you name it, a host of other health topics, and has been the director of CCP for a number of years, and under her leadership, the center has really thrived, and you'll see an example of that this morning. So Susan, welcome. I'm gonna ask Susan to briefly describe this project. After that, we will talk a little bit about the methods underlying this project, go back to some of the findings, and then we'll end by showing you how you can take advantage of the dashboard. So Susan, do you want to start by giving us a little background about the project?
Sure. Thanks very much, Rajiv, and good morning. Hello to everyone, and thanks for joining us. Just a bit of context before I dive into the specifics of this project. CCP has worked extensively in risk communication, starting way back with avian influenza, and We were very active in the West Africa Ebola outbreak, more recently around Zika, and of course now COVID. And in all of these contexts, communication plays a really essential role in helping to keep people informed about what's happening and what they can do and should be doing to protect themselves and their families and communities. As Rajiv noted, these situations tend to be quite dynamic, and we've certainly seen that with COVID. So the ability to communicate the right information quickly, clearly, and regularly is critical. And as we know, right now, preventive behaviors are still the best tool we have at present to curb the pandemic. In general, our work in these contexts focuses on coordination, but as well helping to ensure that teams have easily available content, tools, and other resources they can use to implement strategic risk communication and community engagement interventions. And this also means having access to good data and information to inform effective messaging, which is in an emergency setting can be challenging to collect at best. And that leads us into our collaboration with Facebook. And it emerged through our mutual desire to see how we might leverage our respective organizational strengths for public health in general, but for COVID specifically. Clearly, Facebook has an enormous reach and presence in the digital space and is moving forward on a number of partnerships through its Data for Good initiative. And CCP has very deep SBC expertise and the networks on the ground, including with the established risk communication and community engagement groups. These are the groups that focus on communication in the emergency settings. We started initially with Facebook by connecting the country-level Facebook COVID-19 sites with the trusted sites within the Facebook COVID Information Center that they had established. We also worked with them to optimize use of the Facebook platform to support a recent PMI President Malaria Initiative Seek Care for Fever campaign. And both of these efforts tied in with programming under the USAID Global Breakthrough Action Project led by CCP. At the same time we were working on those initiatives with Facebook, we started the collaboration on with Facebook and MIT around the opportunity to assist with the development, analysis, and dissemination of the COVID-19 Knowledge, Attitude, and Practice Survey. And just to say, the ability to look at COVID-related KAP data in 67 countries and trends over time in 20 countries is just an incredible opportunity for the field. Getting this data into the hands of the policymakers, programmers, and other stakeholders on the ground quickly and in an accessible format is, we think, of immeasurable value to those responsible for making decisions about and managing the communication efforts. In particular, we're very eager to get this data into the hands of the RCCE groups, those are the risk communication community engagement groups, who can use it to inform their implementation, along with whatever other data and information they may have at hand that's locally available. That's really our immediate goal. And we've worked very closely with Facebook and WHO to pull the dashboard together in a way that we hope makes it accessible and, most importantly, actionable to those teams. We'll hear a bit more about the potential applications from Doug, but just expect that the data will help the teams understand what messaging needs further emphasis, which channels are best to reach different groups, who are the trusted sources of information, and around how COVID, the threat of COVID is perceived. There's also data on vaccine acceptance, which obviously will be very important once we have vaccines available. And I think with that, I'll stop. But again, I just want to end by saying how really excited we are to make this data available to the community. Thanks.
Thank you, Susan. So let me now turn to Dr. Stella Babalola. Stella is the Director of Research and Evaluation at CCP. She's also a professor in the Department of Health, Behavior, and Society. Stella is a demographer by training with more than 30 years of behavioral research experience in various parts of the world. She's also worked in family planning, malaria, and HIV prevention, and has extensive experience in sub-Saharan Africa as well as West Africa. Stella is going to talk to us a little bit about the methods that underlie this project. So Stella?
Good morning, everyone, and thank you, Raji, for that introduction. Next slide, please. So the data that we are presenting that you can find on the dashboard are derived from a multi-wave survey of COVID-19, focusing on the prevention behaviors, for example, hand washing, social distancing, and use of masks, and their determinants among Facebook users in 67 countries. In 44 of those 67 countries, the survey was implemented at one point in time in July 2020. In 23 of those countries, it's about multi-wave survey, collecting data every other week among the active Facebook users. And sample size, of course, varied by country, but it was at least 3,000 per country per wave. So we are talking about a large data set here. Next slide. So Facebook did not actually collect the data directly, but what Facebook did was to promote the survey on newsfeed. And when a user clicks on the link, they are directed to a platform that, that is hosted by MIT to complete the survey. And a person has to be at least 18 years old to be eligible for participation. I want to say that no individual identifiers were collected during the survey. Next slide, please. So the survey covered multiple domains, including questions on social demographic characteristics, on information sources, including, for example, exposure to information sources and trust in information sources, prevention behaviors, the most obvious ones and the one not so obvious, and also the psychosocial ideational determinants of prevention behaviors. As some of us know, an understanding of the ideational factors associated with a health behavior is important to enable program planners to develop potentially effective programs. Programs that address the relevant ideational variables for a particular behavior have a greater chance of succeeding in changing people's behaviors. The additional variables assessed in this survey include knowledge, perceived severity of COVID, perceived susceptibility to COVID, perceived self-efficacy to take action, descriptive norms about COVID, and about COVID prevention behaviors. Also, we collected information on behavioral intentions and also perceptions about governmental and local communities prevention efforts, about their adequacy. Next slide, please. So the questions were organized into 13 blocks, and I will tell you later why this is important to know. They were organized into 13 blocks: information exposure, knowledge about treatment and positive cases, vaccine acceptability and use of healthcare services, of course, social demographic characteristics, information sources, and basic knowledge about COVID-19 transmission and vulnerable groups. The other slide, next slide, please. The other blocks included physical distancing, what do people understand about it, and what are the descriptive norms around physical distancing, risk perceptions and locus of control, general practice of prevention behaviors, and also recent practice of prevention behaviors, including also the perceived efficacy and perceived social support for those behaviors. Also, behavioral intentions, travel has impacted, whether or not COVID has impacted their intention to travel or their actual travel, and employment and work. Thank you. Next slide. So I said, the questionnaire, the survey tool was divided into 13 blocks. No respondent received all questions. This makes it possible to minimize the time burden on participants while still collecting reasonably meaningful data. Everyone received the first 4 blocks, information exposure, knowledgeable treatment, vaccine acceptability, and social demographic characteristics. In addition, 4 respondents in the 44 snapshot countries, they received the information source, that block, information sources, trust, and needs, plus 3 randomly selected additional blocks. In the 23 multi-wave countries, respondents, in addition to those 4 blocks, were shown 4 randomly selected blocks. So, in essence, each respondent has the possibility to answer questions from 8 blocks. Thank you. Next slide, please. So the data that we are working with here are weighted data. Weighted not just to take into consideration the non-response, so that the sample is representative of active Facebook users, but also because Facebook users tend to be different in terms of sex, in terms of age from the general population. Then using post-stratification techniques to adjust for the differences in sex and age between Facebook users and the general population. Next slide. So several types of analysis were implemented, including univariate analysis, just looking at weighted proportions, weighted means for the preventive behaviors, the socio-demographic characteristics, the ideational determinants, and other relevant variables for each country. Also, we went beyond the data to source data, beyond the survey data to source data from externally, including sources of data about burden of disease. We also classify the countries into groups based on the region, based on the Human Development Index score, so that we are combining. You will see on the dashboard that we combine the survey data with externally sourced data. Next slide. The data also enable us to conduct bivariate analysis so as to assess variations in ideational variables by socio-demographic variables by region and COVID-19 burden of disease, as well as how prevention behaviors vary by ideational variables and also by socio-demographic variables and region and COVID-19 burden of disease. Because some of the data, a portion of the data is multi-wave, so we are also able to perform trends analysis to look at variations in additional variables over time, variations in how additional variables are changing over time, and how they are changing, yes, over time, but also by some determinants, including socio-demographic variables, region, and the burden of disease for the country. We also looked at variations in the prevention behaviors. Variation in prevention behaviors, again, over time, and how those are changing by additional variables, how they are changing by socio-demographic variables over time. Thank you. Next slide. So finally, we are able to do multi-variable analysis, with more sophisticated analysis, looking at, for example, multivariable logistic regression, decomposition analysis, multi-level analysis, to assess the independent association of prevention behaviors with relevant socio-demographic and ideational variables. So in essence, we have quite a robust data set here, and we are going to be telling you how you can access the data. Thank you.
Thank you, Stella. So clearly, this is quite an extensive list of variables that the data set has. And just to reinforce what Stella said, the data are also accessible to people throughout the world. And we really hope that you are able to make extensive use of the data. So I want to next move to Dr. Doug Story's presentation. Doug is associate professor in the Department of Health, Behavior, and Society at Johns Hopkins University. He's also the director of communication science and research at CCP. Doug has 40 years of experience in health communication and social and behavior change communications throughout the world. He's worked in some 36 countries on a wide range of health and environmental issues, focusing mostly on behavior change and social change. He's also the former chair of the Health Communication Division of the International Communication Association. And Doug is going to talk to us a bit more about the data that has already been collected and how that fits with CCP's goals. So Doug.
Thank you, Rajiv, and greetings, everyone. So what I'm going to show you is a sort of a brief introduction to some of the things that you can learn from this data dashboard. This is not a comprehensive report or summary of the results. As Stella has indicated, this is an extensive database and there's much that can be done with it, but I hope to illustrate a few of the things that you can understand through the data visualization in the dashboard that will spark ideas for your own strategic planning for COVID communication, as well as perhaps some ideas for further research that can help clarify some of the questions that these data raise. So when you open the dashboard, you'll see an introductory screen like this with a world map and clickable countries. These slides, I'm not going to show you the live version of the dashboard, but some screenshots from it. But on this screen, you can choose countries that you would like to focus on. And in the lower left-hand side of this screen, you will see options to introduce several filter conditions. You can look at particular WHO-defined regions of the world and zero in so that the dashboard presents data from those countries. Or you can identify particular countries that are of interest to you. In this case, I've just sort of arbitrarily chosen Uganda, and you can see that Uganda is highlighted. And so the results then would be presented with a focus on Uganda. Next slide, please. As Stella said, we have a number of different content areas, and I'm going to sort of walk through a few of these with you to illustrate what you can do with the visualizations that are provided in the dashboard. Predictive behaviors is the first block, and we'll see examples of how common those behaviors are across countries of the world, as well as the norms around those behaviors and self-efficacy to perform those actions as well. There's a block of visualizations related to knowledge and information sources, including symptoms and treatment, availability of treatment and vaccines. There are a number of questions about the sources of information, COVID information that you are exposed to, as well as your trust or the credibility of those sources. There's a block of questions about attitudes, including those perceived risk and efficacy variables that Stella talked about, as well as attitudes toward potential vaccines when they become available. There's also one visualization that allows you to look more closely at countries by the local caseload, either the most recent number of cases reported in that country based on, again, on global surveillance data, as well as a rolling average of those cases. And then finally, there's a section of the dashboard that allows you to tailor your search and your investigation by identifying up to 4 countries, allowing you to compare the results across the different variables in the data set for those selected countries. Next slide, please. So what I'm going to do is show you a few examples of what you can learn from the data visualizations. And one of the first things, of course, that you might want to consider is to look at those main behavioral outcomes or those main ideational determinants of behavior. And you can do this within a particular country. You can look at which of the 4 main behaviors, which we'll see in just a moment, are more common, which ones are less common. Within a country, you could also look at the various ideational factors, ideational determinants of behavior, and see which ones are more prominent, which ones are more common, more positive or more negative, so that you can begin to develop a profile of a country that you are interested in and try to understand what's happening with COVID-19 related behavior and why those behaviors are occurring. Now, you can also use the filter conditions at the beginning of the dashboard that I showed you a moment ago to compare countries. How does one country, country X, compared to others? You might want to see how a country where you work compares to other countries where there might be similar conditions or contrasting conditions for that matter. And you can do this globally, that is look at a particular country against the global backdrop. You can look at it regionally and inspect countries in regions of the world where perhaps you work or conduct research. And you can identify selected countries, specific countries that you would like to investigate and display those together. Next slide, please. So here's the first illustration. This is one of the visualizations that you'll see in close to the top of the dashboard. This shows the global pattern of self-reported prevention behaviors. And as I said, we have 4 main behaviors that are the focus of this survey: mask wearing, physical distancing, hand washing, and self-isolation. And what you see in these rows are the percentages of people in the countries that were surveyed who report mask wearing, physical distancing, hand washing, and self-isolation. There's a black bar that shows the average, the global average for each of those behaviors. And the countries that are at the high end and low end of that distribution are labeled. But you can, this is not a live version of the dashboard, so I can't show you this, but you'll discover this very quickly as you explore it yourself. You can roll your cursor over these circles and the name of the country represented there will pop up. So there are a number of things that you can observe from this. You can zero in on particular countries if you like and see where they fall against the global average. There are some big takeaways that you might want to consider. For example, hand washing and mask wearing are somewhat more common globally than are physical distancing and social isolation. So there are some big picture items that are big picture ideas that can emerge from this sort of global view, but you can also zero in on particular countries to see where they compare to the global average. Next, please. Here's an example of how you might tailor or drill down a little more to understand differences between countries. So in this case, there are 2 screenshots here. One that shows the WHO region that they define as the Americas. And at the bottom is the WHO region that they define as the Eastern Mediterranean region. And you can see a number of things, sort of big picture takeaways here. For example, physical distancing, if you look at the top shot, physical distancing is more common in the Americas than it is on average in the Eastern Mediterranean, those 2 circles, the 2 red circled blocks of countries. Another thing that you might observe is that the variance or the variability in the self-reported behaviors is somewhat higher in the Eastern Mediterranean. That is, the countries within that region differ relative to each other more strongly than is the case in the Americas, meaning that behaviors, some are higher, some are lower, but they tend to be somewhat more consistent in the countries of the Americas than they are in the Eastern Mediterranean. Next slide, please. And then we can drill down, if you like, on particular countries. And I've selected Bangladesh for no particular reason, but just to illustrate where Bangladesh stands against the global backdrop. In Bangladesh, you can see that about 64% of the respondents reported practicing social distancing compared to a global median of 76%. So Bangladesh is a bit below the global average. And 82% report wearing a mask. That's the top band of this visual, compared to 88% globally. So again, Bangladesh is a little bit below the global average on self-reported behavior. And one way that you might use this information is to think about behaviors that deserve some focus in your communication strategy, or perhaps in your research agenda. So where behaviors are lower than desired, you might want to consider developing communication strategies that could motivate those behaviors and push or encourage those behaviors more strongly than they currently might be. Next slide, please. Here's an example of the visualization for knowledge of COVID symptoms and treatment. There are a number of variables here. The percent of people who report knowing 3 or more symptoms of COVID-19, the percent who know the population groups that are most at risk of infection, the percent who know that there is no approved treatment or vaccine at the time that the survey data were collected, and then there's the did not know any of the symptoms as a comparison. And again, there are a number of things that you can observe by inspecting this visual. Globally, knowledge of who is at risk is lower than knowledge about symptoms or availability of the vaccine. And you can see where Bangladesh in particular stands in this. There's a big gap between the percent in Bangladesh who report knowing who vulnerable groups are and the global average than there is between Bangladesh and the global average on some of the other measures. So again, how would you use something like this? You can inspect the countries that you're interested in, see where they fall in within this global pattern, and then consider whether you might need to develop a communication strategy to increase certain kinds of knowledge that are lower than you might desire or lower than you think are appropriate or necessary in a country of interest. Next slide, please. Stella referred to ideational variables, and knowledge is one of those, but also attitudes toward or attitudes about the threat of COVID-19, whether it is a severe disease and whether you are susceptible, are important potential predictors of behavior. In this slide, you see 3 of the variables, the threat variables that were measured in the survey. One is whether you think that that infection would have COVID-19 infection would have serious consequences for you, whether it's a threat to your community. And then third, whether you believe that people like you are at risk of becoming infected. We sometimes refer to that as susceptibility, and the other 2 as perceptions of severity. And again, there are a number of global or high-level takeaways that you can derive from a presentation, from a visual like this. Globally, fear of infection and the perceived threat to the community are somewhat higher compared to perceived susceptibility. And then again, for no particular reason, I've highlighted Indonesia here just to show how you can zero in on a particular country of interest. People in Indonesia are more likely to report a greater threat, a greater perception of threat and susceptibility than other countries on average. The difference is less striking on the perception that COVID-19 is a threat to the community. But again, how would you use some of this information? Well, you might, again, zero in on countries of interest, and if perceived susceptibility is low, for example, communication strategies might try to educate the public about behaviors that can put them at risk, that might make them more susceptible. For instance, not wearing a mask in public. Next slide, please. Another question that was asked was whether a person would accept a vaccine for COVID-19 when it becomes available. And this visualization presents the results of that question by world region. You can see those listed across the top. And then within each region, the percentage who say that they would accept a vaccine are arranged from lowest to highest. So you can see within each world region, there is a range of acceptability. And again, for no particular reason, I've highlighted Indonesia in the WHO Southeast Asia region. You can see that Indonesia is among the lowest, or is the lowest, the country that reported the least acceptability of a vaccine when it becomes available. Within that region, among the countries in that region. It's certainly higher than in some other regions. WHO European region is considerably lower on average. So you begin to see a pattern of where countries fall in terms of acceptability. And of course, there are communication implications for this as well. When vaccines do become available, it may be necessary to communicate to the public about the beneficial effects of vaccination, the protective effects. And this might be particularly important in countries that at this time report low acceptability of a vaccine. Next slide, please. So another thing that you can do with these data are to begin, and I say this sort of cautiously, but begin to explore possible causal pathways. For example, you might want to explore possible explanations for higher or lower values in a particular country. If country X, Indonesia, Bangladesh, Canada, Singapore, is lower on a particular behavior than other comparison countries, you might want to then compare those countries on key ideational variables. Are there patterns that might explain those differences? Differences in masking norms or lower perceived risk and so on. Now, we have to caution you to interpret results like this with caution, because the associations that you can observe from these data are not necessarily causal. They may be, but they're not necessarily so. But they can be suggestive, and they can encourage more investigation to understand the relationships better. It might encourage you to look for additional studies or research that's available, or maybe design your own research to test that relationship and confirm what these data suggest may be the causal pathways. Next slide, please. So, for example, in Bangladesh, if you look at these are two screenshots that are superimposed. In Bangladesh, we saw this earlier. There about 64% of people in Bangladesh report that they actually practice physical distancing. But the top visual there shows that only 32% of people of respondents in Bangladesh believe that that is a norm, that physical distancing is a norm. So you might ask yourself, what explains this gap? And is lower practice of distancing related to perceived norms? So we may want to do some additional investigation to confirm that suspicion that low perceived norms are related to lower physical distancing. Or you might consider whether it's important to help inform people that their perception of the norm is actually at odds with the actual practice. More people are practicing physical distancing than you might know. And that might influence the acceptability of that practice or motivation to physically distance yourself. Next slide, please. There's also a presentation that begins to look at the relationship between self-confidence or self-efficacy to prevent COVID-19 and the practice of those four main behaviors. And so for each country, you see where the self-confidence level lies. And globally, this is quite low, about 50% or less across the board. You can scroll through the countries and see it will change as you move down the list. But you can begin to see where confidence might relate to the practice of these behaviors. Next slide, please. And as we go down the list, we see that sort of self-confidence, it's ordered by level of self-confidence. We see that fairly low levels in places like Italy and Spain and Portugal. And although this would need to be tested statistically, it looks as though low levels of confidence are associated with more consistent behavior. You can see for Italy, Spain, and Portugal, where confidence to manage this is low, that people are worried and they are practicing these behaviors, all four of those behaviors, at a fairly high and consistent rate. So again, cautiously interpret this in terms of causation, but it raises interesting questions that we would want to investigate further. Next slide, please. And then there is a slide. I won't go into this in great detail because this is a bit complicated. You need to spend some time thinking this through. But we also have created a visualization that shows a selected variable. You can choose the variable that you want to investigate by the level of prevalence in that country, either the number of cases or the rolling average of cases. And in most cases, the difference between those two is relatively minor, but as you scroll through different behaviors, you see the patterns of behavior, the patterns of attitudes changing and becoming more variable or more consistent over time. So I won't describe this in detail because we're running out of time, but this is a very interesting graphic that you can use to explore the variables in the data set that are of interest to you against the backdrop of local prevalence. Next slide, please. And then I described at the beginning very briefly the way that you can choose particular countries to compare. So in this case, I have, again, sort of arbitrarily selected 3 countries, Kenya, Tanzania, and Uganda, all East African countries with some similar cultural and socio-demographic characteristics. This allows you to see what the patterns are in countries that you think may be comparable or interesting in some way. And just in this case, Tanzania is consistently lower on most of the variables than Kenya and Uganda. And this would probably encourage you to ask some questions about why that might be. Now, I haven't prepared the slide screenshots to illustrate this, but we did explore the caseload and media exposure for these 3 countries, and we found that caseload is relatively low in all 3 of these countries, but the knowledge of COVID symptoms and of who is at risk, as well as perceived threat of COVID-19 to the community, is also lowest in Tanzania. But exposure to several kinds of communication sources, radio, television, health workers, newspapers, are also lower in Tanzania compared to Kenya and Uganda. So this suggests perhaps that Tanzania might want to consider, as they develop a communication strategy, might want to consider using communication channels that reach the greatest number of people to educate the public about COVID-19 risks and help them realistically assess the threat of coronavirus in their own communities. Then that might address this gap between Tanzania and other countries in the same region. Next slide, please. Now, I've just alluded to the possibility of doing some media and channel analysis, and this is the last bit that I want to illustrate before I pass it back to my co-presenters. The questions that were asked about the media and the channels that are widely considered important sources and trusted sources allows you to explore which channels in particular countries or globally reach more people and are more trusted. And one of the uses of these data are to help you prioritize the use of channels for your communication strategy that have the highest reach and the highest trust, because those are most likely to have more effect on public attitudes and motivation to behave. Next slide, please. I'll just illustrate this very quickly with 2 examples. The slide here is filtered to highlight Indonesia, but you can see the pattern of exposure and trust in all of the media, color-coded by these bars on the right. You can click on these to highlight one or more of the channels. But I've highlighted Indonesia just to show you where 3 of the common communication channels fall in terms of exposure and trust. And what you can see here is that online sources and television are the highest for Indonesia. That is, more people report getting COVID information from those sources. But online sources are less trusted than television. On the other hand, health workers are not reaching as many people with COVID information, perhaps because of the interpersonal channel. It takes more time and more effort to reach more people. But health workers are a highly trusted source, comparable to television. So this might encourage you to think about what sources to use for communication with the general public in Indonesia. Next slide, please. And in contrast, another country in the same region, Singapore, people also reported very high exposure to online sources, but an even lower level of trust in those sources. Yet health workers are a main source of COVID information in Singapore and a relatively trusted one. Television is also widely trusted, but doesn't reach as many people with this type of information as do health workers. So again, by drilling down on certain countries, we might see what the possibilities or the options are for choosing the right channels to reach our audience. Next slide, please. That's it for me. That was a lot of information. These are meant just to simply illustrate the kinds of investigation that you might do using the visualizations. There are many, many other questions, as Stella was saying, that you can explore in this dashboard, but also if you download the data and do some of your own analysis, there is much more that you might learn from these. So do enjoy using the dashboard, and we'll be happy to answer any questions in a few minutes. Thank you.
Thank you, Doug. I just wanted to let our technical people know that I seem to have lost video access. So if you could restore that, that'd be great. So next, we're going to hear a little bit about the potential users of this dashboard and how it might be used. So I'm going to now turn to Jenny Solo, who is a social and behavioral scientist working at the intersection of medical anthropology, public health, and infectious disease outbreak response. She is currently assistant professor at Temple University College of Public Health. She is responding to the COVID-19 pandemic with the WHO's Global Outbreak Alert and Response Network, also known as GORN. So Jenny?
Thank you for that introduction. Good morning, good afternoon, and good evening, everyone. Once again, my name is Dr. Jenny Stolo. I am the Risk Communication and Community Engagement Focal Point for GORN Research. I see many of our partners are on this webinar, but for those of you who may not be familiar, GORN is the Global Outbreak Alert and Response Network. We are a network of over 250 partners around the world. Our main users include the World Health Organization regional offices, ministries of health, academic institutions, technical networks, and NGOs. Next slide, please. A major strength of the dashboard is the variety of data it presents. The dashboard will present data at the global, regional, and individual country level, as well as longitudinally. Having these features is incredible as it allows for comparison across regions as well as countries. Longitudinal data is a major strength as longitudinal data are often lost in emergency, outbreak, epidemic, or what is now a pandemic. In these situations, resources are often spread thin, limiting the capacity to support longitudinal data collection and analysis. Additionally, we hope the data in the dashboard can be used to provide insights into monitoring and evaluation, as well as policy modification. Uniquely, this dashboard allows for comprehensive data visualization, as well as insights into respondents' attitudes toward and use of different information sources, as we just saw. Next slide, please. We aim for this dashboard to support collaboration across countries. Once again, data will be available at the global, regional, and individual country level. Therefore, we hope countries use this dashboard to compare across areas and collaborate to improve both regional as well as country level COVID response. The dashboard is quite interactive and can provide data visualization, which once again will help our partners communicate with their stakeholders. Furthermore, we hope the data from the dashboard can be used to support the monitoring and evaluation of COVID-19 response efforts, as well as policy implementation and reform. We aim for these data to be used on the front lines and to improve response efforts. Lastly, this dashboard provides snapshots into respondents' social norms, sources of information, trust in information, as well as information sources. We hope these can provide a lot of support for our continued international efforts to produce, evaluate, and modify COVID-19 risk communication, health education, and promotion. Speaking of promotion, next slide, please. I do want to keep this brief. I know we're over time. So GORN, as a partner in all of this, it's been an absolute pleasure to advise on this project. We are very excited about the outcome and outputs. We will be disseminating the dashboard via several channels. First is via the COVID-19 working groups. There are a variety of working groups across our partners as well as across the WHO operational pillars. These working groups are uniquely focusing on COVID-19 response, and we hope the dashboard's information will help to support their endeavors. We will also be disseminating these resources with our regional offices, as we hope this will support their needs. And lastly, the dashboard links and information will be made available via the GORN Knowledge Hub, which is a repository of COVID-19 resources for our partners and beyond. Please do connect with us if you are interested in using this dashboard or if you are currently using the dashboard. We would love to collect anecdotes and support your success. Thank you so much.
Thank you, Jenny. I know we are running out of time, but I was wondering if I could just re-invite the panelists back for just a few minutes of further Q&A. I know that there are a number of questions that people have asked in the question chat box. Perhaps I could start with Stella. Stella, so there are a number of questions about the underlying methods that are being used. And in particular, I was wondering if you could talk about some of the questions that have come up, which are, is the data collection ongoing? Is it adapted to the local context? And are there data being collected from crisis and conflict areas?
Okay, thank you, Raji. So the data collection is still ongoing in the multi-wave countries. The most recent, I believe, was like a week ago, and that must have been the sixth round. And we still have at least 2 more rounds to go. So the tool was translated into 51 languages, so it wasn't just in English or French, it was in local language. And so the questions were adapted to make sense in those countries without necessarily changing the meaning, the spirit of the questions. I don't know if I answered others' questions or said something else.
I think you did. Thank you, Stella. And Doug, if I may ask, I think there are questions about the inherent biases, and I'll sort of focus in on 2 of them. One pertains to users of Facebook being representative or not of larger residents in each of the countries. And then the second bias perhaps has to do with self-reported biases and the extent to which people are accurately reporting what they are doing. Could you address one or both of those?
Sure. Stella can talk to the issue of representativeness a bit more, but it's true that Facebook users tend to be more literate, more tech savvy, and so on. But MIT did use some post hoc weighting to help bring the sample in line with the characteristics of the local characteristics, the local profile of the countries that were surveyed. They used existing socioeconomic and demographic data, for example, to profile each country and then weight the data so that the proportion of respondents, the weighted proportion of respondents, was similar to the country profile. So although it's not a perfect way of understanding what, let's say, low income or rural, more isolated populations might be doing, the weighting helps to balance that to some extent. But that, again, that just sort of suggests that there are some important questions that may need to be pursued further with other research. These data should be taken as being somewhat suggestive, but requiring further investigation. Sorry, what was the other question about?
Self-reported bias.
Self-report bias, sure. So that is always an issue with survey data, and there will be some perhaps exaggeration of self-reported data. The sample sizes are quite large, so that bias may not be as dramatically affect the interpretation of the results. But I think you could probably assume that that kind of self-report bias is consistent across all of the samples, across all of the countries and the respondents. So if we look at the results in relative terms, we could still draw some fairly robust conclusions about the proportion who report masking versus the proportion who report physical distancing. So although survey data and self-report data are not perfect, they are fairly robust. And if we interpret them with an eye toward the potential for some bias, then I think our conclusions can still be justified.
Great.
I don't know, Stella, if you want to say anything more about that.
No, I think you said it all. You know, the post-certification took care of age and sex differences. So like you said, other issues still exist in terms of differences between, you know, the data that we are seeing and what would have been obtained if this was a random sample of the population. So, yeah.
Great. Jenny, could I come to you and ask you, what are some of the ways in which GORN will be able to promote the use of this dashboard? Could you speak to that a little bit, please?
Thank you for that. Yeah, we are very proud of the outputs of this, and we will, as I previously noted, be sharing this across our partners. We also, as GORN Research, aim to fill any research needs and gaps that our partners may have. This is, as we've been saying, a very robust data set. It is going to be a continuous data set. And as resources start to diminish for COVID-19, I think we're seeing this globally. There are other needs within communities and within countries. So we hope to be able to support whatever COVID-19 data, visualization, etc., that is needed at a country, regional, global level. We will be promoting as GORN Research through our WHO regional contacts, as well as via the GORN Hub, as well as through our working groups. Thank you.
Fabulous. I know we're coming close to the end. I would like to end by asking Susan a question. So if Susan wouldn't mind coming on. Susan, I was wondering what you imagine might come out of the use of this dashboard in an RCCE committee at the country level. What do you think they might do differently once they have a chance to look at this data? And could you talk about that in the sort of the larger context of the work that CCP is doing?
Sure, thanks. I think, you know, our hope is that the users of the data, and those RCCEs in particular, will be able to take that data and understand how to tailor their existing efforts using that data. So that involves communication as well as the community engagement piece. And I noted somebody had a question on that. So for example, if, you know, in a given country, the RCCE can see that health workers are highly trusted, they may then take that and understand where the messaging needs to be emphasized, a little bit discussed by Doug, and ensure that the health workers are equipped with the right information around that messaging, so that they can, again, use this data to tailor their program efforts and make sure they're really focusing on the right things, because there's a lot of information out there. And yes, you can continue talking about and informing people about the, you know, the preventive behaviors, but if they already know that, what else might you need to do? And I think this data can really help the folks on the ground tailor their work based on this to make sure that it's most effective.
Great.
I also want to note that there's an additional dashboard release that will be coming within the week that enables users, it will enable users to drill down specifically on some of the demographic data, looking across geographies, gender, and age. So more to come on this as well.
Wow. I think we covered a lot of ground in this brief hour. I know that lots of people probably have lots of comments. I am going to next direct people's attention, those of you who can stay a bit longer, to a short video that we're going to play that is going to demonstrate how this dashboard could be used. So with that, those of us who can stay, please do stick around, and others, I just want to thank you for this great participation this morning. So thank you very much.
Welcome. Thank you for your interest in learning more about the dashboard for the global study on knowledge, attitudes, and practices around COVID-19, or the KAP COVID Dashboard. This dashboard is designed for policymakers and health communication practitioners for use in evidence-based approaches that encourage adoption of behaviors to prevent the spread of COVID-19. This data visualization tool was produced by Johns Hopkins Center for Communication Programs in collaboration with Facebook's Data for Good, MIT, WHO, and the Global Outbreak Alert and Response Network. To begin our orientation to the dashboard, as you can see, this dashboard includes the results of a study conducted in 67 countries in July 2020. You are able to display results globally, by region, or by country, and make comparisons. In order to visualize the comparisons, begin by selecting a country or a region. This will highlight your country across all results below. This can be done by selecting a country on the map or from one of the drop-down menus. The drop-downs provide the option to select a WHO region or a single country. You can select a single country to see how that country compares to its neighbors. Let's choose Kenya. Pay particular attention to the icon with the magnifying glass. This is where you'll find additional information and insights related to a particular visualization. These insights have been provided by Johns Hopkins Center for Communication Programs researchers to help you in interpreting the results. Scrolling down, you'll see how our selection, Kenya, is highlighted among the results. This allows us to see not only what respondents from Kenya reported for mask wearing. In this case, 91% of Kenyans reported wearing masks 1 week prior to the survey. But you also see the country comparisons and groupings. Which countries had similar levels of reporting to Kenya? 4 key prevention behaviors are reported. In addition to mask wearing, you'll see results on physical distancing, hand washing, and self-isolation. For additional insights, such as the range of responses around distancing and self-isolation, and how to assess where to increase prevention efforts, be sure to click on the tooltip. In the graphic, note the median for all responses is represented with a line, and that each dot represents a weighted average of responses per country. As you scroll through the visualization, you'll continue to see Kenya, the country we selected, is highlighted in each visual. You'll see the scrolling feature is embedded in order to access the entire list of countries. Here is the highlighted country. In this graphic, we can see both the percentage of individuals who wore a mask in the last week and the percentage that believe this was a community norm. When you scroll up and click on the Insights icon, you'll see there is more information about perceived norms and what factors impact normative beliefs and behaviors. Taking a look at this side-by-side bar chart describing physical distancing, we can scroll down to where Kenya is. This shows a wide discrepancy between the belief physical distancing is a norm at 33% and the average reported behavior at 77%. This is actionable data for practitioners developing health messaging. The last visualization in the practices section has to do with confidence. You can see by the variation of the colored dots where the reported behavior rates fall compared to the reported level of confidence respondents had that these behaviors would prevent them from contracting COVID-19. Again, as with all the visualizations, the country we selected is highlighted. And if you click on the Insights icon, you can learn more about the relationship between preventive behaviors and confidence levels related to COVID-19 prevention, as well as why these confidence levels appear to be so low worldwide. The knowledge section of the KAP COVID Dashboard visualizes respondents' knowledge of COVID-19 symptoms and treatment. The survey was hoping to answer the question, was general knowledge of COVID-19 consistent across the globe? Within this graphic, you can see the wide variation in knowledge across the countries. Globally, people are less likely to know who is most at risk than they are to know about symptoms or available treatments. Again, to learn more about the graphic and interpretation, you can go to the Insights icon. We know that misinformation is a problem in every country. However, which sources of COVID-19 information were most trusted? Which sources were most frequently accessed? Note our selected country, Kenya, is still highlighted in the different quadrants. Also note the labels in each quadrant. You'll see in Kenya, television as a source has high exposure, with 82% of respondents reporting exposure to television, as well as high trust, with 70% saying they trust information from this source. Other sources, such as healthcare workers, have a high level of trust in most countries. In the high exposure, low trust quadrant, you can see online sources, meaning that while people see these sources often, fewer people trust the information they receive online. Messaging apps on the whole are reported with the least amount of trust, while newspapers and radio mostly fall below the median trust level. You can filter by information source. Here you'll see all of the instances of radio and where it falls in terms of trust and exposure. Information in this visualization helps practitioners determine which source is best for their audience. In the attitudes section, two areas are explored: fear and vaccine acceptance. Respondents were asked if they feared serious outcomes, if they believed the threat of COVID-19 to their community was dangerous, and if they believed people like them would become infected. Fear can both be a motivating and a demotivating factor in regards to prevention behaviors. So policymakers and practitioners will need to identify individual factors specific to their country. By hovering over the data points, you can see where each country compares to related to each concern. In this visual on vaccine acceptance, countries are grouped with their WHO-defined region for a comparison. Hovering over each of the bars will show the percentage of those respondents in each country who said they would be willing to accept a vaccination for COVID-19 when one becomes available. This next chart looks at case severity and reported behaviors in two ways. In the first chart, countries are classified by COVID-19 severity using the per capita case count at the time of the survey. In the second graph, they are classified by their 14-day percentage change in case count at the time of the survey. Using the pull-down menu, you can select the question you would like to see graphed across the range of topics. The last visualization provides you with the ability to compare multiple country responses to all of the survey questions. In this example, you see a comparison between Kenya, Tanzania, and Uganda. You can select up to 4 countries You can also filter by category. It is our hope that these comparisons and the graphics above will encourage reflection and global exchange of successes, challenges, and strategies for increasing prevention behaviors, and managing COVID-19 infections locally and in relevant ways. Please explore the dashboard. We would love to learn about how you've used these data in your work. You can email your feedback to ccpinfo@jhu.edu. Thank you.
While Marcella pulls up slides with some links to the study methods and the data source, I would like to thank everyone for attending today. And please know we will email out a recording of the webinar along with a copy of the slides. So again, thank you for everyone. Thank you for attending and have a good day.